meiosis. It results in production of a gamete with an extra chromosome 21. So this one, it will increase if the the risk of having non-disjunction Down syndrome increase with the increasing maternal age. So when we do the cryotype, the baby will have 47X if the female lah. If the baby is female, 47XX, meaning additional 21 chromosome, or if the baby is male, 47XY with additional 21 chromosome 21. For the translocation, as I have mentioned, it can be between the genetic information will be translocated into another chromosome 21 or into another acrocentric chromosome like 14, 15, 21, and also 22. So if the translocation between chromosome 21 and the other acrocentric chromosome, the offspring may be aborted, balanced translocation carrier, or Down syndrome, or normal. But if the translocation occur between chromosome 21 and 21, it can either be non-viable or Down syndrome. So the baby karyotype is 40, if it's female, 46XX, and the translocation 21Q arm to the 14Q arm, or 46XY if the baby is male, translocation 21Q arm to the 14Q arm. And as I have mentioned, usually patient with these types of Down syndrome, usually the parents lah ada balanced translocation carrier. So in example, mak dia 45XX, in which translocation of 21 Q arm to the 41 Q arm. So for the mosaicism, in which there is non-disjunction occurring post-fertilization during the first or the second mitotic division. So usually the baby karyotype will be 47XX lah. So yang tu additional lah kalau additional info kalau nak tengok. So the most common is non-disjunction. Okay. Faham kan setakat ni? Takut saya tak reti sangat explain. Okay ke? Setakat ni? Everyone? Okay lagi ya?
InsyaAllah.
Okay, next. So this is like pathogenesis lah. As you can see, daripada atas there are 3, non-disjunction, Robertsonian translocation, and also the mosaicism. All of these will lead to the overexpressions of gene on chromosome 21. So the offspring will have Down syndrome lah. So we have patients with dysmorphic features such as single palmar crease. All this one I will show on the next slide. And then there is also like delayed developmental milestone, intellectual disability, hypotonia, hypothyroidism, and then there is risk of having leukemia, progressive hearing loss, lens opacity and cataracts, early onsets of Alzheimer's disease, and congenital heart disease. BSD is the most common lah, if not mistaken, and then congenital malformations of the GI tract, imperforate anus, duodenal stenosis or atresia, and Hirschsprung disease. Okay, next. So these are the clinical features of patients with Down syndrome. So the patient will have delayed mental milestone as mental retardation. As you can see on the gambar yang ada physical, mental and social characteristic of Down syndrome, as you can see the developmental of patient with Down syndrome is a bit late, quite late if you look, okay? And then we have delayed motor milestone due to hypotonia or hyperflexible joints or acrobat sign. You can see in the picture, if for normal baby dia tak floppy lah. If patients with Down syndrome, dia akan nampak floppy like the pictures. Okay, and then for the head, the patients might have mild microcephaly, brachycephaly, short anteroposterior like the picture tu. Nampak kan macam anteroposterior dia tu. That one. And then wide posterior fontanelle and large anterior fontanelle ni saya tak ada picture. And then fine silky hair. For the eyes, the patients may have hypertelorism. Hypertelorism is white space eye, as you can see in the diagram. Epicanthal fold, you can also see on the diagram. Upward slanting of eyes. and Bruchfield spot. Brush sebenarnya. Silap aja sebenarnya. Bruchfield spot ni ada on the next slide. Okay, next slide please. That one. Yang gambar mata tu, the Bruchfield spot tu. Small, typically white spot arranged in a ring. Okay, then we continue the clinical presentation of the head. The patient will have low set ears, small nose with depressed bridge or flattened nasal bridge, and then the mouth is small with protruding fissured scrotal tongue in a child more than 6 years, and then delayed teething. For the heart, the patient might have congenital heart disease in 50% of cases lah. And then for the abdomen, actually for the abdomen there are a lot more, but I'm not sure because macam ada yang masuk, ada yang tak masukkan yang ni. So this is ada yang I masukkan is distended with umbilical hernia and also intestinal atresia, which will lead to obstruction of the GI. And then genitalia, small size, hypogonadism, and also undescended testes, which is frequent. Okay, next. So for the hand, the patient usually have short and broad. We have the simian crease, as you can see the one's transverse crease. Boleh nampak kan dekat gambar. And then the clinodactyly, the little finger is incurved due to the rudiment middle phalanx. And then the wide ATD angle. Kalau nampak on the picture yang dekat tengah tu, yang ada angle tu, trisomy 21 tu. Tu ATD angle tu. And then for the feet, it is short and broad. There is also wide gap between the first and second toes, and there is increased skin crease. Nampak macam kaki tu agak banyak skin crease. Okay, next. So these are the complications. Okay, the complication like immunodeficiency, the patient will have recurrent infection, on the chest or skin, otitis media. And then if you look even to manage otitis media, there like certain macam ada info untuk patient with Down syndrome how to manage them. So for the neurological, the patient will have moderate to severe mental retardation, which can due to the accidental trauma, autism, increased risk of senile dementia of Alzheimer, atlantoaxial instability with risk of spinal cord injury, and then for the cardiac, congenital heart disease. For the respiratory, recurrent chest infection, obstructive sleep apnea due to the large tonsil, adenoids, and tongue. And then for the genitourinary, renal anomalies, and hypogonadism. For the hematological, I read that acute myeloid leukemia and also ALL, acute lymphoblastic leukemia. Tapi acute myeloid leukemia ni 20 times more common. For the endocrinal, acquired hypothyroidism, diabetes mellitus, Addison disease, or adrenal insufficiency, if I'm not mistaken. Gastrointestinal anomalies such as duodenal atresia, Hirschsprung disease, imperforate anus, annular pancreas. And other complications are obesity, hearing loss, vision loss, and also psychiatric disorder. Okay, next. So for the investigation, nak diagnose ni mestilah guna karyotype. So karyotype for the baby to confirm Down syndrome, and then which type of Down syndrome, and then to assess the risk of recurrence. Okay, kalau baby tu ada translocation type, macam yang saya cakap tadi, usually one of the parents is balanced translocation carrier. So for suspected anomalies for echocardiograph, because patient usually have congenital heart disease and hormonal assay. If I'm not mistaken, this one is for the thyroid problem. So for the prenatal diagnosis, how we can screen is maternal age, because by increasing age, the first type of Down syndrome yang dan disjunction tu akan increase risk. Maksudnya mak tu kalau makin berumur, like let's say the mother's patient is 40, the risk is 1/100. If the mother's patient is 40 above 45, 1/50 risk of getting offspring with Down syndrome. And then for the fetal ultrasound at 15 to 20 weeks, we measure the knuckle pad thickness. If you can see lah in the picture dekat belakang leher tu, knuckle thickening. And then we do test like maternal alpha fetoprotein. Biasanya mak dia akan low lah. Unconjugated estradiol, low, beta HCG elevated. For PAPP-A is low. Karyotyping for maternal amniotic fluid cell or chorionic villus sample for early diagnosis in suspected cases. So kalau amniocentesis tu dia ambil amniotic fluid, for the chorionic villus sampling tu dia ambil something about chorionic villi if not mistaken. Kalau amniocentesis tu dicocok daripada atas kan, but for chorionic villus sampling ada yang transvaginal dengan transabdominal, but the picture shows is transvaginal. And it also differ by weeks lah. Kalau tengok amniocentesis tu 15 to 18 weeks, but for the chorionic villus sampling 10 to 13 weeks. Okay, next. So this is for the management, for the genetic counselling of the parents and education of them about the case and possible progression. So we have to tell lah the recurrent risk. Contohnya kalau ada 1.5% risk tu plus maternal age related risk. Oh, I forget to add the risk lah, tapi yang I ingat, if the mother's patient is 40, 1/100 risk of getting Down syndrome. If the mother's patient is above 45, 1/50 risk to get ni. And then if there is a parental translocation, there is higher risk of getting Down syndrome. So for other family members, same as the general population, unless translocation runs in the family. So this one, individual with Down syndrome generally infertile, but if they do have children, significant risk for a child with an extra chromosome. So diagnosis is confirmed by chromosome analysis lah. And then we have to give general health support like good nutrition, vaccination. Sebab this patient senang dapat infection, so they have to sentiasa completed the vaccination lah. And then we have to management of complication. If the patient have heart defect, we have to surgery to manage that. And then abnormal thyroidism, if hypothyroidism, we give hormone replacement. And then for hyperthyroidism, we give medication that can regulate the thyroid. So rehabilitation, as any case of mental retardation, there are early intervention program, occupational therapy, speech therapy, special education, special skills training. Kalau tengok, actually dia macam for each year tu daripada umur tu dia macam ada follow up dia sendiri sebab nak check hearing, vision loss. Yang tu yang saya faham, tapi I'm not sure in Malaysia because all I have read usually dekat overseas. Okay, that's all. Ada apa-apa tak faham ke? Sebab saya awal-awal tu explain takut tak faham ke? Okay ke? Okay.
Tanya skip boleh?
Boleh.
Nak tanya kan Aina kata untuk yang first type of Down syndrome tu kan yang non-disjunction tu. Yang tu kan kalau increasing age like over 35, over 40 tu. Tapi macam mana kalau macam mother tu dia baru nak dapat anak at that time ataupun dia lambat kahwin, so itu kira macam primigravida, and primigravida kan lagilah dia ada banyak lagi ada complications tu kan. So what are your advice to these parents? Mesti kita kena bagi tahu juga kan tentang the risk of getting the Down syndrome baby kan. So do you have any advice on patient?
I think we just have to inform lah, maybe apa yang saya faham lah, macam bila contoh dia datang untuk untuk mengandung kan, preconception counselling kan yang tu kan. Rasanya kita kena bagi tahu risk yang tu semua, tapi risk yang tu semua, tapi macam contoh saya baca ni kan, kalau contoh macam mana nak bagi tahu kalau anak dia ada Down syndrome tu, kita macam kena bagi tahu like dia kan sebab Down syndrome kan boleh hidup about sekarang sampai sekarang ni median average dia punya lifespan tu macam sampai 50 lebih kan. So kita kena bagi tahu macam apa yang dia kena buat untuk macam anak dia early intervention program tu. Lepas tu macam kena scan, vaccination, kena assess health dia. sentiasa. Yang tu yang saya tahulah. Tapi kalau as like dia baru nak mengandung tu, kita bagi tahu je lah risk of getting the Down syndrome kan. If I'm not mistaken, yang tu je lah. Anyone else ada opinion lain?
So is it answer your question? What is your question again?
Macam ni kita nak bagi tahu dekat mother tu. Macam about the risk. Bagi tahu macam sebab dia baru prima gravida dan baru nak dapat anak umur let's say more than 40. Jadi kita mesti kena bagi tahu juga ada
What is
risk.
the age of the mother? What is the age of the mother?
Let's say 45.
Okay, so maknanya pregnant or not yet pregnant? This one kalau kahwin lambat lah. For you kalau kahwin lambat ya. Because nowadays sometimes medical officer ni jadi specialist baru kahwin kan. So if you put as 45 tu mujur lah ngandung nak oyaknya. So apa tu kalau Mak Saleh tu 55 pun siapa kau baru mengandung tu tak tahu lah tengok dalam tu. So maknanya they did this gift ke apa benda lah kan nak pregnant umur 50 something overseas lah. Tapi kita ada risk maknanya 52 I think over in USM the eldest punya mother yang kahwin yang semula jadi pregnant lah is 52. Cuma ni bukannya ramai once berapa juta orang tu seorang kan. So if you talking about mother, kalau you kata mother yang cross 40 kan, kalau tengok sini pun dia consider as increasing age of maternal age tu dari segi non-disjunction tu more than 35. Tu dah tinggi dah kan. So sama kalau kata 40. So I don't know what do you mean by that. So kalau misal kata dia kahwin lambat, maknanya you nak cakap berapa persen ke macam mana ni? So kalau umur dia 35 and above, kalau kata 40 ni, dari segi Down syndrome ada chance ke tak dapat chance? Ada risk lah dapat. That's why kalau get pregnant at earlier age kalau boleh lah. Tapi jodoh ni kita tak boleh nak ni. So kita terima seadanya lah. So your question is apa benda? To tell the risk ke apa benda?
Bukan terus je macam ni nak macam bagi advice lah kat dia orang. Macam just bagi tahu macam awak ada risiko ni. Sebab takkan kita nak cakap direct macam tu, more to ethical issue lah.
Kenapa pula you tak bagi direct? Memang you have to tell directly lah. Kenapa pula nak beralasan? Kenapa pula kena
kalau alasan
berlapik-lapik?
cuma macam bukan
Kenapa
berlapik
you nak kena
maksudnya.
berlapik? Kalau umur dia 45, you nak berlapik lagi ke? Dia panggil berterang lagi bersuluh ke macam mana?
Bukan berlapik maksud saya, cuma macam ni cara yang terbaik lah untuk bagi tahu dia orang macam tu je.
So,
just macam more to ethical issue je lah.
Cara tu you pergi tanya counselor lah kalau nak tanya betul-betul. You're talking about you have to tell the parents, you have to tell the mother basically, you have to tell. Sebab I think they know that the risk of Down syndrome or any malformation, the elder you get your age, the higher the risk, isn't it? So kita beritahu yang tu. Cumanya kalau you tanya I thought you punya question, I want to state how many percent. Is it a question like that? Saya mengandung berapa persen nak cakap? Is it like that you want to ask?
Tak pun sebab persen tu
kan?
macam
So kalau tanya saya, I'm asking a person yang expert in Dr. Rawani lah kot. A person in expert in Down syndrome, I will ask how many percent if I were to tell my patient if their age is 45 years of age, itu soalan saya. Maknanya the exact, is there any reference that we want to give to the mother? Sebab dia, I don't know, you nak berlapik macam mana? Kalau umur tu macam on the higher side sikit, there is a risk of getting kita kata abnormal child, isn't it? There is higher chance, okay? But not to say that Down syndrome umur 25 pun tak dapat. No, kalau you tengok ni kan. Tapi kalau non-disjunction, this more in the older age group. Sebab kita ada mosaic dan kita ada juga translocation. But it is very rare lah. So kalau patient tu dah berumur, you cakap terus saja lah. There is a chance of getting. Cumanya always comfort the parents by maknanya there are certain investigations that we can do to ni. Cumanya bezanya dekat Malaysia, even though you know that your child is a Down syndrome, we can abort. Cannot do abortion as compared to overseas, dia boleh buat abortion, itu bezanya. So kalau kata ada risk, so kita always comfort by screening. Okay, what are the screening? So dalam case ni, your friend already illustrated, isn't it? The investigation, satu by taking amniocentesis, dia panggil apa? Triple tu. And then you do the ultrasound, you tengok for knuckle rigid, knuckle kan, thickening. So kalau misal kata you buat tu memang normal, so hopefully tak ada apa-apa lah. Okay, cumanya mungkin ada something yang abnormal. Kalau kata umur 45, you tak boleh lari lah. But we pray hard lah untuk tak ada kan. Tapi bagi saya kalau kata macam mana nak cakap, saya kalau umur banyak, saya cakap terus terang sajalah, there is a chance. Cuma kita orang Islam selalu tampung dengan doa. Kita doa, kita doa, kita doa tak? Tapi kalau dia nak marah juga, I don't know lah. Kalau you kata, they will sue us ke by telling the truth that, sebab saya rasa tak kasar kalau you cakap there is a chance. Okay, but we try to exclude by doing certain investigations during pregnancy. Cuma saya takutnya bila you buat tu takut tersilap. Kata tak ada, dah ada. Yang tu kalau dia sue kita. Kata tak ada, doktor ni ada pula. I don't know lah. Kalau orang nak cari duit, dia akan menggunakan lah semua benda tu. So kalau saya cakap direct saja, cuma kalau you asking me berapa persen, I tak boleh jawab lah. Mungkin I kena cari. Maknanya kalau umur 45 tu, berapa persen kalau dia minta percentage. Okay, I tak boleh nak cakap. Cuma I know it is higher lah. Cuma the way kalau kata older age group tu lebih pada non-disjunctions other than others, isn't it? But those are the commonest pun. But we do have umur mother 20 dan ada Down syndrome, kita ada, bukan tak ada. Okay, is it okay question tu? But I think
Okay,
bila kita
thank you,
cakap
Prof.
tu kita soft spoken lah kot. I jarang yang nak berselindung-selindung sangat. Ada certain benda tu kadang belantak jugalah. Maknanya kalau benda yang direct. Sebab kalau you nak tipu-tipu pun nowadays they can Google themselves, isn't it? Kalau kata tak ada, tak tengok ada. So kadang dia sue kita juga because of not telling everything. Okay, this slide is very important for you to read. Kalau tak faham lagi, you can always ask the question. Cumanya, untuk Down syndrome ni, this is, kita ada trisomy kan. So this is the paling common lah, trisomy. Okay, management, the keywords untuk management tadi adalah early intervention program. Namanya adalah early intervention program, but I tell you, I think quite extensive jugalah. Okay, dia punya program tu. Cumanya when the patient was delivered, okay, mungkin kita ambil umur yang mungkin tua ataupun mungkin mother yang biasa-biasa juga umur, still having a risk, isn't it, of getting this Down syndrome. So dalam counselling part tu, ada dalam principle of counselling other than you nak berlapik tak berlapik tu, untuk Down syndrome, another thing kalau kita when to break the bad news. So Down syndrome boleh keluar lah sebagai ni third year kan. So dalam final year mungkin kita bagi OSCE how to break the bad news. Okay. Saya jarang nak menggunakan to congratulate the newborns. I don't know lah. Tapi yalah sometimes kalau macam Prof Hans tu dia do congratulate mengucapkan tahniah lah di atas kehadiran orang baru tu. Cumanya dalam kes ni sad sikit to say lah kan. Cuma our empathy tu mesti keluar lah. Walaupun kita congratulate but still ada some empathy on our face. So bila you break the bad news, always both parents mesti ada. Kita mesti ada both parents ada, okay, dari segi counselling because you're asking about the counselling part. So both parents ada, we have to have chaperone. Ada seorang yang ada sekali dengan kita because dia boleh tuduh macam-macam but you don't have witness. Okay, so you kena ada chaperone with you so that kalau dia nak sue pun ada seorang yang kita kata backup. Okay, kurang sikit lah. Kita kata perkataan kasar ke apa benda ke. So ada chaperone yang menjadi bukti then you kena documented lah dalam folder tu masa counselling tu. Any case lah I suppose. Some more kalau ada dysmorphic features. And then satu lagi the baby must be there. Okay, the baby must be there. Both parents mesti ada. Kalau ada seorang satu tak boleh lah. Kalau boleh dua-dua ada. Ada baby, ada chaperone and ada you. And bilik tu kalau boleh bilik yang accepted, maknanya tak ada orang lalu lalang and quite quiet kan. Nanti you nak kena menjerit-jerit pula kan. Distractors, okay. And then tak tahulah dari segi tisu tu nak kena ada ke sebelah ke, letaklah tisu just in case you need the tissue, isn't it? And then dari satu seginya simple, we use a simple term, okay. I don't know kalau kata with the help of, sekarang kan senang kan, you boleh ambil laptop ke apa benda ke apa. Kalau perlu assistance masa you nak explain tu kan. Use simple word, jangan guna medical jargon. And satu lagi dari segi prinsipnya adalah bila kita cerita ni, we did not say A to Z about Down syndrome. So maknanya dia ada step by step. Okay, step by step. Mungkin kalau first time dia terkejut kan. So dia terkejut lah kan. Kalau unless dia dah pregnant, dia dah tahu dah, mungkin anticipate lah dari segi down. Tapi kalau tak pernah tahu, then lagilah you kena bagi masa for them to takut-takut masih lagi dalam denial punya ni. Sebab setengah orang kalau CP case cerebral palsy case, I think kadang ada yang denial sampai umur anak 5 tahun ke atas. Okay, down ni I don't know lah, mungkin lagi awal lah kot they accept. And another thing when you explain, you did not explain A to Z. Maknanya when you explain cukup-cukup, misal kata dekat neonate tu, for the first visit tu, mungkin you terang kat dia features dulu. So you have to show to them apa benda features tu. Okay, and then anticipate one or two problems saja, complications saja during that particular time. Okay, yang paling important. And then after that mungkin you akan jumpa lagi kan, another few days later you jumpa, mungkin you boleh top up lagi lah at certain level. So we did not straight away say sampai umur tua berapa life expectancy ni. Kalau I don't know lah, kalau first visit tu I won't say lah about life expectancy, but I will say maybe to comfort them that the Down syndrome is very chubby, apa dia panggil, is a very, kita panggil the words, correct words to use, because they are quite lovely or charming punya ni kan, anak dia segitu, unless ni I don't know whether you want to say or not, tapi dalam buku, dalam jurnal, bukan dari segi counselling tu, dia adalah very lovely punya ni kan, kids kan. Cumanya if they have congenital heart disease, mungkin lebih a little bit difficult lah kot dari segi management. So otherwise they are quite lovely punya kids. Okay, so kalau first time, kalau I ask the presenter, sorry I lost track siapa presenter ni, I know what are the things kalau kata you want to highlight during your first visit if I'm talking about the complication related with Down syndrome?
Complication related.
Problem related complication. Jangan
Is it
jawab
for the
easy tu, jawab terus lah.
okay. We have to do surgery for the heart defect.
Again?
We have to manage the complication, like if the patient have heart defect, we have to do surgery.
Tolong kirim salam. Dapat dah kirim salam ni. Baru first visit, baru 2-3 jam budak ni lahir, nak buat lalu ke? Ingat dia counselling. Your friend asking how to counsel. So dalam counselling, this is the thing. Bagi I tak ada berlapik, cakap je lah. Tapi you punya masa tengah pregnant kan. Cuma kalau tengah pregnant, janganlah risaukan orang duk pregnant tu. Comfort the parent. Ingat comfort. Jangan sadar. Okay, tapi kita akan buat certain investigation and the prayers boleh menghalang sesuatu keburukan daripada berlaku kan. So always encourage, walaupun dia ni bukan orang Islam pun, they also can pray to some extent. So pray can prevent kan. Apa yang sudah ditakdirkan boleh berubah dengan doa. So yang tu key points. Okay. Lambat lah, I jawab je lah. Letih tunggu jawapan.
Sorry.
Dah pukul 4, 4:30. Macam mana nak habis topik lah, letih lah macam ni lah. Okay, apa benda jawapan?
Pray tadi kan.
I pun dah bercakap dah pagi tu, kalau suara tak sedap tu minta maaf lah.
Tidak je doktor.
Sebab klinik pun bercakap macam ni juga. What is your answer?
Tadi saya cakap pasal tak, maksudnya tak bukan soalan doktor, adakah
orang tu anak cacat ni depan mata ni, anak Down, adik cacat lah, adik Down
apa yang saya kena
nak cakap apa ni? Okay, kita akan masuk ke ward. Okay, masuk ward ni kita nak buat apa? Patient definitely will be admitted in our ward. Will be admitted in NICU all Down syndrome by right. Unless yang escape tu duduk kat postnatal, you pun tak perasan nak buat macam mana. So kalau you clerking the patient, bila you present Down syndrome as a long case, you have to tell us when the patient being diagnosed as Down syndrome. Is it in utero? So maknanya in utero bila buat ultrasound tu dah tahu dah. So bila dah tahu mungkin dia buat some chorioamnionitis plus minus lah, mungkin setengah tu tak buat. Setengah buat lah chorioamnionitis, amniocentesis. Okay, so mana tahu dah. Ataupun memang tak tahu, So bila lahir saja tahu. So is it during postnatal ward round or is it that during the vaccination only noted that the patient is having developmental delay. So kalau bagi saya nak tahu bila being diagnosed, bila Down syndrome being diagnosed. Okay. So cuma dalam kes yang senario ni kita memang jumpa patient dekat postnatal ataupun dah masuk ward. So maknanya you have to explain tu kan. So the apa benda dah tadi? So why you need to admit the patient? So satu, they have kalau kata features tu they have protruded tongue. Okay, and I know why should this patient having protruded tongue? Nampak protruded tongue, why?
Yep.
Because they have
Because of the
small maxilla small. So maxilla is small. So lidah tu terkeluar. It is not the big tongue. It is not due to the big tongue. It's just the maxilla is small. So that's why nampak protruded tongue. Okay. And then bila nak kata, okay, bila patient ni kita nak kata dia Down syndrome, you jangan tengok flat nasal bridge, because flat bridge ni tengok anak Melayu pure ke, anak Jawa pure ke. Okay, sebabnya kita masa lahir pun hidung tu batang dia tak ni lagi, batang hidung tu. Okay, satu. So maknanya put it together. Satu lagi jangan tengok telinga saja. Because sometimes bila lahir ni low set telinga tu bagi I panggil telinga tak kembang lagi. Telinga tak kembang lagi. Sekali tengok lepas kelas Down syndrome akan nampak semua adik jadi down. Faham? Lepas kelas spina bifida semua nampak spina bifida occulta. Itu I lah dulu. Semua I buat x-ray. Sebab semua orang ada dimple. So maknanya not just looking at dia punya hidung ataupun telinga. Isn't it? So the key points mungkin put it together everything. Because nanti parents yang Chinese looking tu dia akan marah tau. Because I pernah kena anak saudara pengarah hospital ke somewhere lah. So dia tak boleh terima, dia marah kita. So that's why maknanya bila kita nak explain tu dia mesti lengkap dia punya ni. So not just you looking at the flat nasal bridge. Okay, so you mungkin nak tengok low set ears. Mungkin you nak tengok single palmar crease. Because those are the key points. Because kalau kata short stubby fingers, budak ni baru lahir very difficult, isn't it? So single palmar crease dengan low set, okay. Tapi low set ni tunggu sebab kalau baru sangat tu dia tak kembang lagi telinga dia tu. So but kalau kata single palmar crease tu very very highly lah. Okay, highly. So bila kita kata adik ni, you dah tengok features dia tu memang cukup lah kita kata dengan semua-semua lah. Satu lagi you kata brachycephaly, isn't it, which is flat occiput. So that's why Down syndrome you don't have to plot the head circumference because dia memang microcephaly. Cuma if you plot the growth chart, remember growth chart for Down syndrome dia ada separate growth chart. You tahu kan? So in exam, tahu ke tak tahu?
Saya pernah nampak je tapi saya tak masukkan dalam
Yang orang lain tahu ke tak tahu ni? Senyap je dia. Bukan pernah dengar lah. Kalau you dapat case, long case you Down syndrome, you kena ambil growth chart yang untuk Down. So basically growth chart ni sebab Down ni kita kata dia memang on the lower side punya weight. So among Down tu whether dia okay ke tak, macam tu lah. So that's why kalau you plot the growth chart for head circumference, dia short and fat lah. Dia short and fat. Under short and fat. So that's why kalau you plot the height of the patient, dia memang below third centile lah sebab dia short and fat. But some ada yang skinny ataupun overweight. So that's why kita plot growth chart yang Down syndrome. Head circumference because dia flat occiput, so they are microcephaly. So tak plot pun tak apa sebenarnya. Okay, kalau Down I think the weight lah yang important. Okay, kat mana dah tadi? So when you explain, you will say the first thing you need to explain to the parents is the poor sucking of the patient, atau bila kata poor sucking dia lemah bukan saja flat, lembek-lembek hypotonia tu. So mungkin sucking reflex also poor, okay. So bila dia poor, dari segi suck dia tu is not strong. So that's why we admit the patient to establish the feeding. You might need to start the rice tube feeding. So kita admit first thing adalah untuk feeding establishment. So while waiting, masa you nak establish feeding tu, you akan monitor lah dia punya vital sign, isn't it? So you look whether is there any tachycardic ke, what pulse pressure ke, to suggest that patient might be having heart problem. Okay, yang kedua, you also monitor, kan semua baby kita monitor bila kita feeding, kita tengok BO dia. Kita panggil passing meconium. But before that, when you do the examinations of the newborn to make sure you put the temperature tu, anal temperature. So bila you check anal temperature tu, you are excluding also the imperforated anus because it is highly associated dengan down imperforated anus. Okay, so you monitor the BO of the patient. So satu feeding, vital sign, BO of the patient. So if the patient is delay in passing the meconium, dia panggil berok yang first time tu dipanggil passing meconium. So kalau patient ada delay in passing meconium because it is highly associated with Hirschsprung. So kalau dia macam ada constipated sebab newborn sepatutnya dia BO banyak kali kan. Sama kalau patient breastfeeding. So dia BO tu per day tu banyak. Is a normal thing. Okay, especially yang breastfeeding. Breastfeeding kadang-kadang constipated, confused pula. Okay. So kalau dia constipated, ada dua benda faktor untuk constipation. Satu Hirschsprung, satu lagi your hypothyroidism. Okay, so that's why kena monitor. So maknanya Hirschsprung, how do you know Hirschsprung? So a simple one will be doing the PR. So there will be gush of air, okay, gush of air masa buat untuk Hirschsprung, and satu lagi abdominal distension. Okay, so this one imperforated anus dulu, lepas tu tengok passing motion, passing meconium, do the PR, gushing of air, abdominal distension, do your ultrasound, and another thing is to do rectal biopsy lah kalau kata ada features. Okay, and on top of that, you are excluding, you are tracing the hypothyroidism. Okay, to exclude congenital hypothyroidism, and it can also contribute to constipation. So, okay. Untuk abdomen tadi you kata I don't know the full list of it. So untuk Down syndrome, key pointsnya dia adalah atretic, bawah atresia. Kat mana-mana asal atresia betul. So kalau you letak satu saja which is wrong lah. Sepatutnya dia ada ileal atresia, duodenal atresia, kat mana lagi? So semua yang atresia, dia ada Hirschsprung atresia. But it is not associated with tracheoesophageal fistula and it is not really associated with tetralogy of Fallot. Okay. So kalau kata cardiac, dia lebih kepada endocardial cushion defect dia tu lebih pada AVST, isn't it? So boleh. So maknanya minum susu dan BO. So you cakap yang ni dulu. You cakap yang ni saja dulu, mungkin the first visit tu. Kan? So kita akan kata jangan risau, kita comfort the parents, kita kata dia adalah lovely child, easy to handle, kan? Cute boy ke apa bendanya. Cakap yang tu dulu. Okay? Boleh. Itu adalah first stage. So lepas tu bila patient dah feeding, okay, at the same time kita akan monitor the heart lah. Betul, heart tu saya akan cerita masa first time. Okay, the heart lah. The heart tu yang akan cerita masa first time. So kita akan buat ultrasound, echo. But doesn't mean that you buat echo sekali then you are satisfied. No. Sama juga dengan thyroid function test. For me, I will do a repeated investigation ataupun echo plus thyroid function test pun I akan monitor because to say that it is highly associated and we know that they are associated with learning disability. But we hope by giving the thyroid function test, it will improve, isn't it? The patient's punya learning punya things lah. So lepas tu barulah keluar you punya semua benda yang disebut tadi lah. Yang important one will be acute leukemia and then dia akan ada association dengan ear infection, nose lah semua. So related with the patient's develop sensory dia akan develop dengan hearing loss, isn't it? Hearing loss, developmental delay ada dah. Lain pada tu that you need to know will be below umur, I think around school age group, tapi I suppose more than 7 years of age. I think you did not mention sebab atlantoexia ada sebut tak tadi?
Ada dekat complication neurological.
Okay. So biasanya umur 7 tahun bila dia naik basikal ni. So dia biasanya either fall in the toilet ataupun naik basikal jatuh. So I think minor trauma lah. I don't know to say that jatuh basikal minor trauma. Minor trauma lah kot jatuh sendiri basikal. Minor trauma tak? Kau macam mana? Kita biasa, kau tak biasa jatuh basikal? Tak biasalah
Biasa.
jatuh. Masa mula-mula naik. Okay, so bila dia jatuh, even dalam toilet, because dia punya the C1 and C2 is not really stable. So there will be a higher chance to develop atlantoaxial dislocation. So kalau jatuh dan ada dislocate C1, C2 ni, this is phrenic nerve kan? Phrenic nerve punya control. So the diaphragm tu kan will be affected and the patient need to put under ventilation, and at the end of the day need to be getting the ventilators for the home oxygen therapy. Okay, for the atlantoaxial dislocation. So bila tua barulah nak sebut pasal Alzheimer kan. Bagi saya bila you kata umur 55 kan, setengah orang tak sampai pun 55. So 55 tu is a good age lah kan. Kalau kata umur dia tak apa, sampai juga umur tua. You always comfort the parents. Memanglah semua orang nak mati 80 ke kita? Kalau 80 I tak tahu ada berapa tahun lagi. I think tak semua orang akan mencapai 80 walaupun mimpi tu untuk dapat 50, 80. So 55, I mean kalau I always take a positive. So this age is basically good enough lah for the patient. Kan? So ada tertinggal ke? So I think kalau kata counselling tu cakap yang tu dulu, but you have written everything about the complication. And apa lagi I nak highlight, but I think that one is important. Maknanya kita cakap step by step, bukan at one go everything. Okay. But if the parents asking us earlier, then because of sekarang semua boleh Google, then you can give the information I suppose. Sebab untuk kita volunteer tu dia ada step by step. But if the mother asking you early like certain things, then can always respond. And always kita kalau kata counselling, kalau kita tak sure ni, we always excuse so that we want to check first ke apa ke, rather than giving the false punya facts, isn't it? Kalau kata facts lah, the first false punya things to the parents. Okay, boleh?
Boleh.
Okay, so hopefully, I don't know, kalau kita pernah keluarkan lah break the bad news ni. Down syndrome can appear as your long case exam in your final year, okay?
Okay, Doctor. Thank you.
Ada soalan ke? I might be tertinggal lah, tapi tak apa sebab I punya slide ni I think quite okay dah. Okay, we go to neonatal jaundice. Bronchiolitis tak apalah, last mungkin komen sikit je. Neonatal jaundice.
Okay, sekejap. Nak share screen. Slow pula. Sab boleh tak tolong share Alia punya tu? Line slow.
Boleh tapi PDF boleh dalam PDF.
Boleh.
Okay, sekejap
PDF pun tak. Okay. Right, so Bismillahirrahmanirrahim. Assalamualaikum and a very good evening. I read to Prof. Sami and also my fellow friends. Today I'm going to talk about neonatal jaundice. Okay, next. By definition, neonatal jaundice is also known as neonatal hyperbilirubinemia, which means yellowish discoloration of the skin, conjunctiva, sclera due to elevated serum or plasma bilirubin in the newborn period, rises above 5 mg per deciliter or 85 micromole per liter. Ada certain books dia kata 80 micromole per liter. Okay, next. Boleh zoom sikit tak? Tak apalah, kalau dia nampak tak apa kot. Okay. Alright, so before kita pergi ke other part of the presentation, so let me briefly explain about the bilirubin metabolism. So it starts with the red cell breakdown, which will release hemoglobin, and then the hemoglobin will be further broken down into heme and globin. And then the heme will be converted into unconjugated bilirubin or indirect bilirubin. It's the same thing. It is basically lipid soluble but water insoluble. So in order for it to reach the liver, it has to bound to albumin. And so albumin is basically the transport protein. So when they reach the liver, it will be taken up by the hepatocytes, and later the unconjugated bilirubin will be converted into conjugated bilirubin or direct bilirubin by the process known as conjugation. This process is mediated by glucuronidase. It is the enzyme. And then later the hepatocytes will excrete the conjugated bilirubin into the duodenum and also the gallbladder. So once the conjugated bilirubin is already in the intestinal tract, most of it will be secreted via feces as stercobilinogen, and some of it will be reabsorbed into the blood circulation and to start the cycle again. And the process is known as enterohepatic circulation. And a little bit of it will be secreted as urine, as urobilinogen. Okay, so kalau kita tengok at the upper part again, the unconjugated bilirubin, like I've mentioned, is lipid soluble. So when the albumin binding is saturated, so there will be free unconjugated bilirubin in the blood circulation. So this is dangerous because it can cross the blood-brain barrier and cause kernicterus. Kernicterus is actually the post-mortem pathologic findings. So meaning that at this stage, that patient is already dead. Okay, next. Okay, so this is basically the causes of neonatal jaundice. So basically the causes is related to the onset of jaundice. If the jaundice start within the first day of age or less than 24 hours, most likely the causes will be hematolytic disorders. It can be rhesus or ABO incompatibility, or it can be due to enzyme defects like G6PD deficiency, or membrane defects like spherocytosis, pyruvate kinase deficiency, and also congenital infection. If the jaundice is between the first day of life to 2 weeks of age, then the most common causes is physiological jaundice. And then we have breast milk jaundice, infection, most probably due to urinary tract infection, and then also hemolysis, bruising, polycythemia. And if the jaundice is more than 2 weeks of age, the onset is more than 2 weeks of age, then you have to check whether it is conjugated or unconjugated. If unconjugated, then these are the causes: the physiological or breast milk jaundice, infection, hypothyroidism. And if it is conjugated, most likely it will be bile duct obstruction or neonatal hepatitis. Okay, next. Okay, so I'm going to touch a little bit about the physiological jaundice or physiologic jaundice. So most of the babies, which is more than 50% of the babies, of the newborns, will have physiological jaundice, and it is due to newborns typically have higher hematocrits as compared to adults. And the red cell lifespan of newborn infants is basically 70 days as compared to adult. The lifespan of our red blood cell is 120 days. So these two factors will eventually cause increase in the cell turnover, and this will increase the release of, the concentration of unconjugated bilirubin in the blood. And then the third one would be hepatic bilirubin metabolism is less efficient in the first few days of life. So this is related to glucuronidase because the glucuronidase enzyme, which is responsible to conjugate the unconjugated bilirubin into conjugated bilirubin, it is inactive in utero. So when the baby is outside the uterus, then it will take some time to adapt with the new situation and to function efficiently. And then the last one would be newborns are learning to feed and working towards normal stooling pattern. And about the feeding, that is why we always look for the breastfeeding of the breastfeeding technique and also the feeding pattern of the baby, because usually the newborns have, because they are learning to feed. So when there is low input of fluid, so there will be less excretion of the stool, and thus excretion of bilirubin in stool may be decreased because of increase in the enterohepatic circulation. That leads to physiological jaundice. Okay, next. Okay, so this is just a little bit. Maybe you guys can read this later. Okay, next. Okay, next. Okay, so this is basically the summary of assessment of neonatal jaundice. So firstly, we have to assess the severity by clinical assessment. You have to press the skin to assess the jaundice, and the jaundice usually progresses from head to limbs. So meaning that if the percentage of jaundice, if the jaundice has reached like lower below the umbilicus and then at the feet, then that is considered a severe jaundice already. And we have to underestimate if dark skin or preterm babies. And if clinically jaundice, you have to check the bilirubin with transcutaneous meter or blood sample. And then we have to also inquire about the gestation because lower treatment threshold if the baby is preterm. Okay, and then for the age, we have to ask because it is important for the onset of jaundice. And if it is less than 24 hours old, likely to be hemolysis and potentially serious. And if it is more than 2 weeks of age, for preterm is 3 weeks, persistent neonatal jaundice. So we need to check if it is conjugated or unconjugated because unconjugated later can cross the blood-brain barrier and cause kernicterus. And then we have to check whether the baby is well or unwell. We have to check for clinical evidence of sepsis and if dehydrated. And then for the risk factors, perhaps any hemolysis, check for antenatal antibodies. If mother is blood group O, it will most likely to have ABO incompatibility if the baby is blood group A. And then if Mediterranean, Far Eastern or Afro-Caribbean, most likely to have G6PD deficiency. And then check also for sepsis, unwell acidosis and low serum albumin if measured. And then for needing treatment, we have to plot the bilirubin on gestation specific chart according to age since birth because we want to know whether this baby require treatment or not. And then we have to plot the rate of change of bilirubin to identify potentially high levels of bilirubin. Okay, next. Right, so for history taking, what we have to ask the mother is basically the age of onset of the jaundice. Like I've mentioned earlier, ada 3, less than 1 day of life, one day to 2 weeks, and then more than 2 weeks. And then previous infants with neonatal jaundice, kernicterus, neonatal death, G6PD deficiency, and then the mother's blood group, which can be taken from the antenatal history, and then the gestation because the incidence of hyperbilirubinemia increases with maturity. And then presence of abnormal symptoms like apnea, difficulty in feeding, feed intolerance, and temperature instability because it might show that there is underlying disease. Okay, next. For physical examination, we have to look the general condition, the gestation and weight, the signs of sepsis and hydration status of the baby. And then we have to also assess the signs of acute bilirubin encephalopathy, which is ABE, for all babies with severe neonatal jaundice. Later, I will explain about the BIND score. And then we have to check whether the baby have pallor, plethora, cephalo, hematoma, subaponeurotic hemorrhage, and then signs of intrauterine infection like petechiae, hepatosplenomegaly. And then check for
Hello? Aya?
the progression. And then the Hello? Kenapa? Dengar tak?
Putus-putus.
Hello? Oh, putus ke? Oh, sorry.
okay.
Sekarang dah okay?
Okay. Tak apa, tak payah repeat.
Tak payah repeat, okay. So the adequacy of breastfeeding, weight and hydration status of all the babies should be assessed during the first week of life. And then the baby's weight loss more than 70% should be referred for further evaluation and closely monitored for jaundice. Okay, next. Okay, so this is basically the BIND score that I've mentioned earlier, the bilirubin-induced neurological dysfunction. So there are 3 components that we have to assess, the mental status, muscle tone, and the cry pattern. It is important if the score is 1 to 3, it shows that this is mild ABE. subtle signs of ABE, and then moderate, which is 4 to 6, urgent bilirubin reduction intervention is
Putus. Tak dengar. Tak dengar. Dengar tak?
likely to reverse this damage. And then for 7 to 9, urgent bilirubin reduction intervention. Anis. Hello?
Okay, dengar.
Oh, dengar dah?
Dia angin
Hello?
kot.
Dengar dah?
Area
Alamak.
I think wing.
Oh, alamak, ayah lihat kau.
Tak hujan.
Hello, dengar tak sekarang?
Dengar.
Okay. Ayah angkat call kejap boleh tak? Ayah lihat call. Ayah tengah present. Ayah tengah present. Nanti ayah call kamu balik Kejap je. I nak present sikit lagi. Okay, hello. Hello, boleh dengar tak?
Okay.
Boleh.
Okay. Sorry tadi ayah call jap. Alright, so basically the point score is used to assess the jaundice, the severity of jaundice of the patient, and also to assess the effectiveness of bilirubin reduction strategy. We want to know either the management we give to the patient is effective or not. Okay, next. Next. Hello? Next.
Ya, dengar.
Next lah.
Next. Then next ke? Alamak, Alia tak berubah pun. Okay, tak apalah, Alia buka slide Alia. Okay, okay, so this is the methods to detect the neonatal jaundice. We can use visual assessment, which is the Kramer's rule. It should be done to all newborn babies. And then we have transcutaneous bilirubinometer, which is the TCB. And if the TCB level are more than 200 unimole per liter. And if it is more than 200 millimole per liter, then we have to do the total serum bilirubin test. And the third one would be the total serum bilirubin test lah. And then for the Kramer's rule, this is what I've mentioned earlier. If it is only at the head or neck, then it is only level 1, and then upper trunk level 2, below umbilicus is level 3 already, severe endolegs level 4, palms and soles is already level 5, and from what I have read, if it
Ayah. Nak hujan kot. Macam mana?
Alia, tak je pun. Tak dengar.
Apa ke?
Oh. Nanti keluar ke?
Bising. Ni siapa punya pula bising ni mesti Nazla.
Saya. Sorry.
Okay, I
Saya, Prof.
tak. So dia terkeluar. But the slide is with you, isn't it? You boleh tekan tak slide tu sementara tunggu dia masuk balik. But this one roughly you want to know, this is grammar rule, isn't it? So next slide, ada berapa slide lagi? Ada two of the next one. She's trying to get back kan?
Tengah reconnect.
Next. 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 I don't know dia ada masalah ke tak tu. Kita pergi ke slide nombor 1 balik boleh? Sebab tadi I ada masalah sikit. Tadi I was out sikit. Sekejap. So this is neonatal jaundice, isn't it? So dia sepatutnya adalah sclera, isn't it? Minimum sclera. So kalau kata maknanya if the patient is having noted to be sclera jaundice, minimum maknanya is about 5 kan? If the patient is above 5, kita biasanya pakai millimol lah. So maknanya micromol ke millimol? Micromol per liter. So kita guna 85. But if you were to convert, kita bagi 17 kan? 17 kali 5 sama dengan 85. Okay? So if you were to convert times 17. Okay, 5 kali 17 sama dengan 85. But usually kalau kita communicate, if you communicate with me, I'm usually using the micromol per liter. So by right shouldn't have any jaundice unless the patient is having more than 85 micromol per liter. Okay, that one sclera jaundice lah, not yet. I think the skin might not be so apparent yet. So next, yang ni adalah mechanism tadi kan. So you should know this one, you at your level barat you should read lah. You should read hemoglobin, isn't it? They start dengan hemoglobin. Okay. So from there, lepas tu kita kena ada glucuronil transferase, isn't it? Okay, you have to have that knowledge. And then keluar, and then you also need to know conjugated dengan unconjugated hypobilirubinemia. So usually kalau kata kalau kata conjugated which is obstructive jaundice, so usually where is the jaundice part? So I suppose the jaundice part tu, the obstructive jaundice part biasanya keluar daripada the hepatic itself lah. So okay, keluar daripada hepatic tu dia ada level dia, intrahepatic tu dengan extrahepatic dia ada level, you read that one. But cumanya dalam pediatric age group, kalau kata adult, because of the mass, isn't it? Pancreatic mass or what, so dia obstruct dekat excretions of bowel, isn't it? Dekat mana? Dekat excretions of the bowel. So tu kalau kata adult. But for us usually the obstructive jaundice-nya dia duduk atas lagi, which is over the gallbladder. Kita panggil biliary atresia, dan satu lagi kita panggil choledochal cyst. Okay? Ada choledochal cyst and biliary atresia. Those are very important for us. Okay, next. So lepas tu the color of our stool because of the stercobilinogen, and the color of our urine because of the urobilinogen, isn't it? Okay, yang ni. Ada ni tak masuk-masuk lagi. Are you contacted her? You cuba ke dia tak mau masuk dah?
Tak boleh. Dia tengah cuba lagi sebenarnya.
Dia tengah cuba, kita tunggulah. Sial pula. So after that, habis dah? Physiological jaundice. Lepas tu, ni apa ni? Sekejap. Ni adalah pathogenesis. Yang ni I rasa this one is too complex kan. This one untuk alo. Okay, next. Okay. Okay. Next. Okay, history. So, dia tengah cuba ke? Rasa-rasa berjaya ke tak berjaya?
Macam tak je doktor.
Okay, tak apa. Is it the weather is not good? I was minggu ni okay lagi lah. Tapi if not that we stop dulu dah. And then we set. We have another one lah kot lah.
Boleh.
Is it okay with you? Sebab kalau tunggu pun tak seronok lah kalau dia tak ada, because dia prepare kan dengan penuh rajinnya kan, kita anti climax pula. Siam pula dia. So okay. I don't know
Rasanya
whether
okey je.
besok saya tak boleh. Bila yang you rasa you boleh? Besok sebab ada appointment. Saya yang ada appointment, so saya tak tahulah kalau saya rasa mungkin saya have early day. Kalau I petang tu saya okay, I don't know. Petang besok you free ya? Tapi kalau I'm using my phone. Tapi kalau
Bila doktor free?
I don't know lah free ke tak, macam malas je minggu ni. Lepas tu sekejap lah. Hari apa yang you free? Kejap lah. Examine. I patutnya correct paper. Lepas tu dia orang kata tak perlu pula correct paper tu yang I payah nak adjust tu. Sepatutnya correct paper on 7. I will be on call on 7. So kalau 7 hari bulan, sekejap 7 adalah
Tu Alia. Dia dengar aku.
So are you okay? So I know
Boleh dengar tak?
Alia kan?
Boleh.
Kak Alia yang
Ya. Ya,
Ya,
Alia.
boleh dengar.
Alia kan?
Boleh. Betul.
Alia, okay. It's a very good preparation. Kita dah tengok dah. Minta maaf kita dah tengok dah slide
Oh,
tu.
dah tengok ke? Tak apa.
Dah ya, kita faham. Tapi kawan-kawan you share. You can send through the WhatsApp lah. Nampak macam cantik juga slide you ni. You can
Okay.
send through our group, boleh tak nanti you share? Nanti kawan-kawan
Boleh,
yang dah
boleh.
baca nanti you highlight yang belakang tu. I start from dulu lah. So I have mentioned to your colleague just now. So it is apa dia panggil scleral punya jaundice tu when the patient is more than berapa? 5 isn't it? 85 micromole per liter. So as you mentioned, cuma you mention dia punya assessment tu at the end, which is the Kramer kan, Kramer homunculus tu. So the Kramer homunculus, remember when all patient came to you, bila kita kelak untuk neonate patient ni, kita kena cakap dia punya extent of the jaundice tu. So yang you berhenti tadi dekat situ kan, so roughly you can estimate kalau dekat mata saja. But I think kalau mata saja, patient maybe not come to us yet. So patient usually dia dekat chest, isn't it? Tapi kalau dekat soul tu, true enough, you would like to a little bit aggressive in your action, isn't it? Maknanya you do cross matching straight away. And usually the staff nurse dia pandai dia buat role dia. Staff nurse kalau masuk ward dia tahu dah, dia akan bagi feeding patient, dia akan put the drip. So that bila you ambil tu you akan repeat another SB. So bila staff nurse dah bagi feeding untuk patient and bagi drip untuk patient, so patient akan BO MPU, isn't it? After kita bagi fluid ni. So at the same time the serum bilirubin also will be coming down. Okay. Cumanya kalau tunjuk you punya Kramer punya tu tadi, homunculus, you stop kat tu tadi. So roughly you estimate, tapi kalau dah sampai ke pump and soul tu dia dah 306. So you remember satu cut off point untuk letak foto berapa Alia? Foto.
200.
Fototerapi roughly, okay. Untuk kita tahu whether photo level or EP level, okay, usually dia ada apa yang dia panggil nomogram, isn't it? So this is serum bilirubin punya nomogram. So maknanya dalam nomogram dia ikut age, prem different nomogram, term different monogram. Understand? So biasanya dia ikut age of the patient and ikut weight of the patient. So meaning that kalau umur 1 to 2 days lagi lower dia punya ET level or photo level. Okay. So I pun mungkin tak ingat. So maknanya kita akan refer dekat nomogram. But untuk term patient, anybody more than 250 250 kalau umur dah mungkin 3 days and above, then those are the photo level. So untuk ET level, it depends on other than kalau kata umur tu dah set more than 3 days untuk term patient, biasanya setengah NICU center tu dia dah letak dah berapa. So it depends on the neonatologist. So kalau misal kata is it dia ambil 340 or 380 or 400. Understand? So different NICU mungkin different. Tengok dia quoting in which particular studies dia ambil lah. So I think USM dia set a little bit higher punya ET level, but KKM usually mungkin around 340. Okay, 340 is ET level. Kalau ni untuk term and more than 3 days of life lah. Kalau day 1, day 2 kena tengok nomogram lah. I pun tak ingat lah. So dia lagi lower lah dia punya EP level. So bila patient you nampak dekat sole and then you dah dapat indirect bilirubin dia tu, total bilirubin dia which is 340 ataupun memang kita kata ET level. So you make sure that you assess neurological, the one that you using the apa benda tadi? BIND ke apa benda? BIND. Okay.
Baik.
Okay, bind tu I tak familiar sangat, but this one for me you are doing the neurological examinations to look for any bilirubin encephalopathy or not. So to say that for bilirubin encephalopathy, kalau kata skor berapa you nak kata mild, moderate, severe ni kan. So bagi saya if the patient is having bilirubin encephalopathy, it is already a chance that the patient will develop neurological complication. So satu, you boleh tengok skor ni, tapi every patient, every infant, every baby who's having poor sucking reflex, okay, kalau tengok sini poor sucking dua. Kalau patient, kalau kata dia decrease in feeding, so bagi saya tak seteruk yang sucking. So kita akan check sucking reflex dia. So kita check sucking reflex. Kalau ada sucking affected tu dia dah panggil encephalopathy dah. Okay, yang kedua adalah moro. Moro ada dalam ni. So moro reflex. Tak ada moro you. So moro reflex. Mana moro? So moro reflex tengok incomplete moro ataupun absent moro. Okay. So moro reflex, sucking reflex. Okay, dua. Kalau ada ni tak bagus. Yang ketiganya kita akan buat motor system examination. So either hypotonia or either hypertonia, or if the patient is having breath reflexes. Okay. So those indicates not good. So bagi saya untuk kata bilirubin encephalopathy maknanya tiga yang important lah for me. One is sucking reflex. Kedua adalah moro reflex. Yang ketiga adalah is there any neurological deficit? Maknanya is there any generalized, bukan kata neurological deficit, ada generalized hyper-breath reflexes. So kalau patient ada poor oral intake or the patient is sleep a lot, that one is pro lah. Tapi kalau ada tiga ni lagi strong, okay, I want to say that the patient is having bilirubin encephalopathy. Maknanya even though we proceed with the exchange transfusion, the risk is already there. Maknanya before your ET tu, before your exchange transfusion, the patient I think more than 50% chance already cross the blood-brain barrier, and a chance that the patient might be having cerebral palsy or sensory neural deafness. Okay, so if you go by this lagi detail lah. Tapi I suppose I don't know whether is it very difficult or not if you want to label as mild, moderate, severe ni kan. Kata satu, kalau kata 1 hingga 3 mild, tapi dia dah ada semua high pitch cry, persistent hypotonia dengan ni mild. So what do you mean by mild? Bagi saya ada ke tak ada. So I lebih kata ada ke tak ada. Okay. But you can use this one lah kalau kata lagi more comprehensive lah you want to ni. So maknanya satu, check the patient. Okay, for Kramer homunculus tadi, that's why you said apa you punya words that every baby, every newborn you assess. Okay. Cumanya your words isn't it, Alia? Cumanya remember Kramer ni untuk patient yang fair skin okay. So kalau dark skin macam patient mungkin Indian, then it's very difficult lah. Untuk our side Kelantan ni tak ada masalah sebab I think mostly Malay. So dari segi colour, skin colour tu tak ada masalah sangat lah untuk tengok ah. Tapi kalau you pakai Kramer ni, you make sure that the patient never put on the photo yet. So once the patient was put on phototherapy, dia dah alter dah. Dia dah alter dah. You cannot really based on this. Understand? Sebab dia dah change dah. Bila kita letak fototerapi tak boleh guna dah. Satu, kalau patient prematurity, one of the complication related ke apa dia panggil complication related ataupun effect of the your phototherapy is the bronze baby syndrome kan? Pernah dengar bronze baby syndrome? So kalau patient prem patient, kalau tak foto, color dia dah kelabu-kelabu asap dah. So you tak boleh nak tengok dah kalau kata extend no. So kalau kata for this one is for patient yang tak letak foto lagi, once letak foto it is not reliable anymore lah. Okay, satu lagi the skin color of the patient. So kalau coloured, dipanggil coloured, kita tak ada coloured sangat lah. So kalau dekat overseas tu mungkin kita panggil apa, black people ataupun Indian yang mungkin ada little bit thick kan, dia punya very dark colour dia tu mungkin not applicable lah, nak tengok sampai mana tu tak nampak. Satu lagi mungkin you press kan the skin tu mungkin nampak ada kan, yang tu salah satu cara lagi lah. Kalau dia gelap sikit you tekan sikit kulit dia tu ada tak macam membantu ke tak membantu. Kalau membantu lah. Kalau tidak, dark skin tak boleh nak tengok. Sama juga if you talking about transcutaneous bilirubinometer. Okay, untuk skin fair tak apa. Tapi kalau dark skin, it might be affected lah. Okay, might be affected. Boleh faham ke dari segi clinical I mention? Cumanya, I suppose kalau kata you talking about neonatal jaundice, you have kalau I dari segi approach, we divide into 3 kan? Ada ke tak ada? Tak ada kot awal tadi. Mungkin I miss. So satu you kata early onset kan? Early onset jaundice or pathological jaundice. By definition mostly akan ambil 24 hours. Cuma kalau nak tambah lagi is about 48 hours. Second will be your physiological jaundice and third one will be your prolonged jaundice. So dari segi physiological jaundice mungkin around 2 days of life to 2 weeks of life, isn't it? So anything beyond 2 weeks of life, dia panggil prolonged jaundice. Okay, we go to the tengok So bila kita tanya you, what are the cause of early onset jaundice? Other name for early onset jaundice will be pathological jaundice. So bila kata pathological, it is not physiology. Maknanya you have to exclude other things. So it might be physiological kalau kata cross 24 hours tu, tapi you kena exclude yang pathological. Nombor 1 dan nombor 2 is okay. But you miss satu you miss, tak ada dalam ni. You miss the sepsis. Where is the sepsis? So early onset jaundice yang important bagi I 3. Satu is rhesus incompatibility or ABO incompatibility and sepsis of any reason. So usually kita blame the group B strep lah. Okay, Mak Saleh mungkin dia ada spherocytosis, kita tak ada. So congenital infection, this one torches. Maybe it's slightly torches ataupun bagi I sepsis tadi yang group B strep. Boleh letak lah tapi bagi I tak berapa ni sangat. So kalau you jawab G6PD, I think even Dr. Prof Hans pun tak akan kata G6PD sebagai early onset jaundice. Okay. But you can trace lah the result whether normal or not normal tu untuk G6PD. But I won't put as the cause for G6PD. I won't, okay? I won't. Cuma the problem with G6PD ni, bila dia jaundice, dia bukan macam budak lain in the sense they are very very fast in the increment of the jaundice. So dia very very fast deterioration. Itu dia punya key points untuk G6PD. Maknanya once dia deficiency, remember kalau kata G6PD balik sebagai result deficient, misal kata dekat postnatal round ke, postnatal ward ke, ataupun mungkin dia masuk sebab feeding problem ke, bila ada saja G6PD deficient, you nampak tinge of jaundice, even tu dekat face, dekat mata saja, straight away put under phototherapy. So kalau I letak straight phototherapy, make sure patient is having good feeding. So tak tunggu sampai photo level. Because bila you tunggu photo level, usually dia very very fast, then you need to do ET. Itu untuk G6PD, faham? Dia very very fast worsening. Tapi kita tak letaklah tak jaundice lagi, letak tak, bukan. Kita letak bila tinge of jaundice. So boleh faham ke early onset bagi saya ambil yang nombor 1, nombor 2 dengan sepsis. Okay. Which is septicemia lah atau group B strep. So 3 tu yang important kalau jawab. Kalau lecturer tanya lagi, you boleh jawab yang lain. Tapi jawab yang 3 ni dulu. Okay, kalau kata rhesus maknanya rhesus negative, and another thing is ABO will be mother O, isn't it? Mother O and
betul.
baby apa. Okay, kita tanya yang tu. And then kalau lepas tu kita tanya you how to confirm, you have to know home test, you balik baca lah. I tak sempat nak elaborate yang tu. Lepas tu dalam physiological jaundice, dia ada 2 which is breastfeeding jaundice and breast milk jaundice kan. Breastfeeding jaundice, breast milk jaundice. So breastfeeding tu lebih kepada patient yang breastfeeding lah kan, sama je dengan physiological jaundice kan, breastfeeding. So maknanya patient mungkin tidur banyak ke, mother kena kejut ke, ataupun kan
Betul.
tak cukup susu ke apa ke. So yang tu dulu you exclude. Breast milk is by exclusion basically. So again bila sampai dalam group yang physiological jaundice punya age tu, which is 2 days until 2 weeks tu, again kita exclude other things. So contoh you tengok sepsis dia, takut-takut ada group B strep kan. Lepas tu you exclude, misal kita tengok umbilical stump dia tu takut ada wet ke, okay. Tengok dia punya hematocrit, lepas tu tengok dia punya kefal hematoma ke subarachnoid hemorrhage, sebab this is dipanggil extravasations of the blood. So any bruises dekat body dia akan menjadi penyebab sebagai apa dia panggil? Penyebab sebagai jaundice lah. So bagi I ambil yang tu. So G6PD duduk sini jugalah. G6PD ada di mana-mana, tapi for me G6PD lebih pada yang macam I cakap tadi lah. Okay. So lain pada tu dalam kes ni Kriegler-Najjar, kita ada satu lagi which is Dubin-Johnson. But if you cannot answer about Dubin-Johnson ataupun Kriegler-Najjar, for me tak fail. Tapi kalau you tak boleh jawab pasal research ABO, G6PD dengan breast physiological jaundice, that one boleh fail lah. Okay, boleh faham lah yang kata dalam masa umur physiological ni. And the last one will be your prolonged jaundice. Dalam prolonged jaundice, very very important, we want to know whether it is unconjugated or conjugated. Dalam jaundice yang biasa, biasanya this is unconjugated kan. So kalau you tengok sini, kita ada dua cara kita tengok. Satu, you tengok percentage. So maknanya kalau go by percentage, if the direct bilirubin tu percentage lebih kurang 15%. So anything 15%, you bahagi direct dengan indirect tu 15%. So that one will be under unconjugated lah, hyperbilirubinemia. Tapi once dia cross saja 30 tu is a definite. So more than 25, you straight away put under conjugated. Okay, so dalam ni tak bagus sebab sepatutnya they mention about biliary atresia dengan choleloccal cyst. Satu lagi will be neonatal hepatitis syndrome. So untuk conjugated hyperbili yang tiga ada important. Satu is biliary atresia, choleloccal cyst and dia panggil neonatal hepatitis syndrome, dia panggil syndrome. So kalau kata neonatal hepatitis syndrome, it is not purely due to intrauterine infection or hepatitis B or C lah ya. So ini adalah syndrome, okay. Dia macam inflammation. So kalau kata medical cause ataupun unconjugated, medical cause very important will be your hypothyroidism, yes. Lepas tu your UTI. So that's why you need to send urine. Apa yang tak ada kat sini? Lain pada tu, I will send gamma GT dengan alpha 1 antitrypsin. Okay. So untuk prolonged jaundice, kalau dapat case, it can appear as your long case in your final year. Kita tak letak you yang physiological jaundice dalam final exam. But it can appear as your physiological jaundice, boleh appear in your apa dia panggil OSCE. OSCE boleh, you kelak boleh. Tapi kalau dalam exam long case, kita letak biliary atresia boleh. Ataupun in fact kalau neonatal hepatitis syndrome pun boleh. So maknanya prolonged jaundice appear as your long case boleh. Okay, maknanya dari segi approach, you tengok conjugated, unconjugated. Very very important for us to do stool inspection. Faham? So maknanya kalau kata mother kata kuning pun you tak boleh percaya kat dia. You nak tengok juga stool tu. So stool mesti, kalau stool color macam susu pekat manis that one is pale stool bukannya yellow stool Susu pekat manis tu kadang nampak kuning-kuning kan. So the mother will interpret as yellow the stool walaupun colornya macam susu pekat manis. So that's why you need to observe yourself. So kalau masa you check during kat klinik, nearest klinik you tu duduk dekat PK kan, kalau you kerja kat situ, you make sure that the mother bring the stool. Kalau BO tu letak, simpan untuk you observe. Kalau dalam ward kita panggil stool inspection. So kita kena tengok. Okay. Kadang-kadang dia ada, kadang ada colour, kadang tak ada colour. So kalau kadang ada colour, kadang tak ada colour, the stool tu usually dia duduk dalam neonatal hepatitis syndrome. Remember as I mentioned just now, bila dekat hepatic dia ada intrahepatic, extrahepatic. You balik cari where is the cutoff point to say where is intrahepatic, extrahepatic. So dari segi anatominya, something yang intrahepatic akan menyebabkan apa? Unconjugated hyperbili. So apa-apa yang extrahepatic, you tengok landmark, dia akan menyebabkan unconjugated kan? Terbalik. Conjugated ni prolonged jaundice kan? Okay. Conjugated. So kalau conjugated, extrahepatic. So doesn't mean that it is biliary atresia or choleloccal cyst, masih duduk lagi dalam neonatal hepatitis syndrome. So kalau neonatal hepatitis syndrome, dia tak ada specific treatment, tak ada specific. So is it clear to you regarding the approach? So maknanya tengok age ada 3. Okay, kalau early onset jaundice mesti buat certain things termasuk comb test. Okay, so lepas tu you tengok kalau physiological jaundice biasa kita tengok Kramer punya homunculus. And then always you do the neurological scoring untuk tengok ada bilirubin encephalopathy. So kalau dah ada, kita beritahu ayah dia. So walaupun kita buat ET, exchange transfusion, the patient is already encephalopathy, having features of encephalopathy. So by doing exchange transfusion tu, dia tak adalah kata patient akan normalize, no. Dia still akan dapat sequelae lah. Cuma the sequelae tu as you mention dalam you punya slide tu kan Alia, ada apa ada cantik tu dia punya flowchart tu. So yang pentingnya adalah sensory neurodeafness dengan attitude cerebral palsy, isn't it? That one yang important. So kernicterus ni sepatutnya postmortem finding, yes, true enough. Tapi I dengar kadang-kadang dia orang guna juga kernicterus ni. So untuk kita panggil bilirubin encephalopathy lah. Sebab by definition kernicterus tu adalah diagnosis postmortem. Patient dah mati ya. Patient dah mati. So apa lagi yang nak highlight kejap. Boleh faham kan? Ada apa-apa nak tanya? Nanti you send, boleh share tak slide you ni? Sebab kita tak
Boleh.
nak tengok semua.
Saya dah share dalam group.
Okay. So any question nak tanya pun takut sebab masa. So yang ni pun satu, bila kita buat, kita ada triple photo. I think tak pernah lagi I dengan 4 foto. I don't know kalau sekarang ada 4 foto. So triple photo ni maknanya satu atas, bawah Billy blanket, bawah Billy blanket, atas foto. So biasanya dia ada distance, okay? Dan tepi. So triple photo yang paling tinggi lah. But we try to create something like macam Billy blanket pakai baju pula. But I think tak dapat lagi lah kot. So satu mesti side effect lah. So I think final year mungkin you tengok detail lah untuk exchange transfusion. Untuk hari ni I tak sempat nak share lah kot my experience on ET tu. Okay. Dari segi complication, because dari segi complication exchange you akan cerita dari segi baby, blood products dengan procedure itself dari segi complication. But if you want to take the consent of ET, dia mesti cerita sampai possibility, kena cerita juga possibility of blood products ada HIV and ada window period. And then satu lagi kalau buat ET tu make sure you kena, dia punya maximum time tu tak boleh cross 2 hours kan. Kalau you buat 40 minit cepat sangat. Buat 2 jam mungkin takut clot dan lagi banyak problem. Okay, so kalau kita tak shake, ada alat pun untuk shake our packed cell. The blood products that we use will be fresh whole blood kan. So this fresh so-called packed cell ni, you kena apa dia panggil, tak boleh you sedimented. Kalau dia sedimentation, so at the end of the day, yang hujung-hujung tu you keluarkan blood dia, you masukkan plasma. Faham? So risk of anemia pula masa, kalau silap cara ada anemia. Sebab at the end tu dia plasma saja you masuk, you buat keluar blood. So lepas tu you nak kena bagi pack cell pula kat patient. So ada double dia punya times of getting HIV. Okay, so that's why kalau buat tu kena ni. But I think this one you boleh tanya I lah kemudian if you interested. Cuma kalau foto ni dia kena calibrated juga lampu dia tu. Okay, berapa 450 nanometer ke apa benda tu. So okay, any question for neonatal jaundice? Okay. So I suppose today is quite good punya preparation. Thank you very much. Okay, excellent. Cuma yang tak present lagi tu you nak continue ke ataupun macam mana? Sebab dia adalah repetition. Anything to highlight? Apa tak present? Is it I know?
Sabrina.
Sabrina nak cakap apa-apa tak?
Can I just share because my presentation is not quite long, just 7 slides.
Berapa minit tu?
I will
I tak naklah balik pernah macam tu kan.
okay, I will get it short.
Important things lah because you dah prepare kan, kita respect lah the preparation.
Okay. Okay, so about acute bronchiolitis, what I want to highlight is about the age of the presentation. It occurs during the first 2 years of life, and the peak age is around 2 to 6 months. And it is
In real, kalau kata long case, you akan ambil 3 years, and anything below 4 years of age, you can entertain as RSV infection. Less than 4 years of age, masih lagi boleh hantar aspirate tu lah. Okay.
okay. Okay, next, it is caused primarily by respiratory syncytial virus and also other virus also. You can read this later. And in Malaysia, it is endemic. But I read somewhere that the annual peak of these cases is usually during November, December, and January.
This is raining season. So kalau kata Mak Saleh, dia winter time. So
Yes.
when you say RSV, dia in our mind, when you say acute bronchiolitis, in our mind is RSV. So that's why when patient masuk ward, kita kata acute bronchiolitis, you send investigation. Kalau kata bukan, diagnosis on discharge, you kena tulis non-RSV bronchiolitis. Because bila kita sebut acute bronchiolitis, it belongs to RSV. So kalau kata send negative, non-RSV. But we did not really bother lah. Kalau kata the other tu, is it influenza ke, adeno ke, rhino ke, we did not really bother because maybe cannot confirm. But one thing that we would like to exclude whether this is RSV or not. Okay.
Okay. Okay, next is the risk factor. So I think the risk factor is about all the risk factor that can increase susceptibility to get the infection. I think you can.
In detail.
Then the pre-existing medical condition that usually lead to severe bronchiolitis. This is the medical condition that once the infants get the infection, so they will have a tendency to get severe bronchiolitis.
So for you to say that the other name for acute bronchiolitis is happy wheezer. Nama dia pun happy wheezer. So dia adalah viral infection. So usually by right, it is very kita kata not much problem to the patient yang normal lah. So it will contribute to the mortality kalau the list is for the right hand side. Maknanya bukan prematurity tu, ex prematurity. Okay. Bagi I lebih kepada a patient ex prematurity, so that's why we have to give the vaccine palivizumab ni quite frequent lah untuk ex prematurity. The second thing yang important will be the chronic lung disease, and then any congenital heart disease or immunodeficiency here will be a patient with primary immunodeficiency. So any patient in the ward, barat you should isolate. But kalau ada limitation, especially in USM, to isolate, so the patient cannot be beside, the bed cannot be beside the patient with X chronic lung disease, cannot be with congenital heart disease or immune deficiency, because once the patients get it, very high mortality. So that's why kalau you dapat acute bronchiolitis, you try to help other teams by asking or by checking the neighbours dekat ward for the patients tu, what is the diagnosis. Okay, boleh? Continue.
Okay. Right. Next is about the signs and symptoms. I read that for acute bronchiolitis, it will start with upper respiratory infection punya symptom, which is coryza symptoms, and then after that it will progress to lower respiratory infection, and patient will present with persistent cough, increasing dyspnea, and also audible wheezing, and also associated with low grade fever, and feeding difficulty is due to increasing of dyspnea, and
For me,
okay,
for me, kalau kata pure viral acute bronchiolitis ni supposed to be quite benign lah. Cuma when you say feeding difficulty, dia dah misleading lah. Misleading in the sense that you have to cover with antibiotic, because kalau kata reduce in feeding, reduce in activity, then you cannot gamble lah by not giving antibiotic to the patient, kan? For apnea, I think in all respi punya infection, for very young infant, less than 2 months, you entertain apnea ni ada 3 lah. Is it due to respi, is it due to neuro, or is it due to cardio, kan? Cuma based on my experience, an infant, for example 40 days of life, if they come with apnea, higher chance they can be a case of pertussis. Okay, so they are not really presented with respiratory noises untuk young infant ni, they come with apnea. So based on my experience, apnea tu mungkin lebih pro towards pertussis, but again you have to exclude lah other respi punya infection like you listed in your slide. Okay.
And then signs the patient can
You
they
highlight
can.
yang important.
Okay, so I think the important hyperinflation of the chest, and then during explantation, there is crackles and then high pitch wheeze. In severe bronchiolitis, there is a sign of respiratory distress, lah. For example, retraction, nasopharynx, grunting, and cyanosis.
Everybody is having respiratory distress. Sebab tu kata
Oh.
happy. So when the patient admitted to our ward, so the criteria tu mesti dia ada respiratory distress because
Oh,
it's
okay.
a specific treatment. So it is okay to allow the patients home kalau you confident enough. Cuma dalam kes ni, the keywords untuk acute bronchiolitis will be hyperinflated chest and happy wheezer, maknanya dia mungkin quite playful and there is a wheezing. And when you auscultate, there will be a scattered crepitations and rhonchi. Itu adalah the keywords. But once the patient's having secondary lung infection, secondary bacterial infection, usually at that particular time, maybe ada something yang lebih, you kata you have to start antibiotics tu. Macam grunting. Grunting for me lebih kepada RDS, respiratory distress syndrome or severe pneumonia. That is my experience lah. Satu lagi is palpable liver spleen. So personally for a patient with hepatosplenomegaly, I will cover with antibiotics because this indicates severity, isn't it? With the presence of hepatosplenomegaly, definitely I will give antibiotics. Sedangkan kalau you kata RDS, you don't have to start, isn't it? Tak start kan? Dia tak ada, dia adalah viral. So you can put this one, tapi kalau saya, kalau ada hepatosplenomegaly, ada grunting with cyanosis, definitely I will cover the patient with antibiotics. Yes, dia betul ada acute bronchiolitis, but we cannot really say 100% that there is no secondary bacterial infection. Kan? So
betul.
safe side, bagi saya those are the key points when I want to
Cover with
add
antibiotic.
on. Okay? I want to cover with antibiotic. Are you agree with me? Kalau you tak agree, tak apa. But that is my taste, my personal experience. Okay?
Okay, Prof. Okay, so next, basically the investigations.
Yang ni satu ni, sorry, you please. Okay. I tak suka sebab dalam exam, kalau you kata acute bronchiolitis, so this is acute bronchiolitis, never mention about ESR. Never mention. Okay. So satu lagi yang you ambil tu, nasopharyngeal swab tu. So ingat, you ambil ke you type sendiri ni?
I ambil.
Ambil daripada mana?
I tak ingat tapi dekat books lah.
Are you sure 100% you copy? Because nasopharyngeal, oh this is one swab. So that one is overseas kot PCR. So for our patient, we are using nasopharyngeal aspirate. Okay, nasopharyngeal swab for PCR is for your pertussis. So for other viral infection, you are kat sini kita ambil nasopharyngeal aspirate. But I think sebab kalau master student dia nak aspirate tau. Aspirate untuk ni. So I think tak tahulah macam mana you ambil ni. Okay, yang ni boleh cut short lah. Ada apa yang nak highlight?
I
tak suka ESR.
Oh, okay. ESR maksudnya ESR tu salah lah.
Bukan, kenapa you nak ambil ESR? Ni bukan TB pun. Kenapa you nak ambil?
Oh, I think because I want to rule out any bacterial infection.
Kok mana pulaknya? You investigation you ni bukan this is not long case. This is investigation. So maknanya it is on, kalau kata macam ni you present how to say you support saja, support. Bukannya you present macam mana? Faham?
Okay.
So you tak present case tau, you bukan case. So maknanya kalau case ni you kata acute bronchiolitis, what should you do? So you present hanya untuk bronchiolitis. Kalau you present case tu, baru you letak you want to exclude. Sekarang ni bukan case kan, dia adalah acute bronchiolitis. So everything towards acute bronchiolitis lah.
Okay.
Sama juga kalau kata dari segi blood gas, kita ambil standard. So if the saturation less than 95% on oxygen, everybody will take the blood gas. Okay? Satu. Maknanya go by saturation. But if you go by respiratory distress, maknanya boleh tengok subcostal, intercostal recession. But I suppose bila ada yang tu you akan check pulse oximeter. So kalau pulse oximeter dia 92, you give oxygen to the patient. So kalau increment, kalau untuk kita biasa kita tengok, kalau ada increment we won't do because almost always when you do the ABG won't be good. So bila tak elok, what is your action? You need to intubate. So when you need to intubate, especially USM, mana ada tempat PICU pun tak ada. So kalau you kata kenapa substandard sangat USM tak buat routinely ABG. So one of the reason is that lah. We don't have place to intubate the patient. So barat when you do blood gas, if it's not good, then you have to add on it. So bagi I, okay lah untuk tengok pulse oximeter. Boleh? So anything less than 95% with oxygen we do. So kalau tak normal, kita kena
Intubate lah.
intervene.
Oh, intervene. Okay.
Boleh ya? So I tak suka inside because of that.
Right. Okay, Prof. I think this is my last slide.
Okay, anything
The management. I think not really much because majority of the management is just from home treatment, which is adequate for
bukan, dia
inpatient.
panggil supportive treatment, bukan home treatment.
Oh,
Dia
supportive treatment.
So kalau kata supportive treatment, one thing if the patient is having respiratory distress, so you need to put oxygen kan, you check the saturation,
Yes.
you put oxygen. So treatment dia oxygen. And then you say just now, reduce oral intake. So remember, reduce oral intake ada dua. Satu, is it reduce appetite? Satu lagi reduce oral intake because the patient is coughing. Dia nak makan, dia nak minum tapi bila minum saja dia batuk. So reduce oral intake. Satu lagi dia tak minat pun nak makan. So yang lebih teruk adalah yang tak tahulah mungkin dua-dua teruk tapi yang reduce appetite lagi teruk. But if the patient yang coughing, teruk juga because there is a tendency for aspiration. So dari segi reduce oral intake, you will put the IV drip. Okay, in respiratory distress, you akan bagi oxygen. And then if the patient is having fever, you akan bagi
Paracetamol.
So tiga tu yang important, okay? Tiga ni yang important. IV drip, oxygen and satu lagi apa? Paracetamol. So now the problem with your bronchodilator, ada ke tak ada sini? Macam tak ada je. So you letak adrenaline ni first time tengok adrenaline. So adrenaline nebulization for me untuk pertussis, untuk a patient who's having stridor, so biasanya pertussis. I think okay, that the evidence is quite strong. So kalau untuk bronchiolitis, dia obviously dia tengah buat lebih kepada is it hypertonic solution or is it salbutamol you want to give to the patient. So overseas maybe dia pro towards giving hypertonic solution. But for our patient, I think our patient, Malaysian or Kelantanese patient, a higher tendency to develop like ada some degree of panggil atopy ke apa. So maknanya when we give nebulization salbutamol to the patient, there will be a marked improvement with your salbutamol. Mungkin kita punya patient kita memang banyak yang kita kata allergic itulah, faham? But the keywords untuk patient yang ada rongkai ni, you can give salbutamol untuk patient ni. Dilution is for smaller patient, zero, maknanya less than 1 year, kita akan bagi 0.25 dengan the dilution 0.25 dengan 0.5, sorry, is it 0.5 and 2.5, okay? So untuk bigger child, dilution akan 1:3, 1 salbutamol, 3 normal saline. Kalau untuk baby kecil, kita bagi 0.5 dengan 2.5 punya dilution. 0.5 adalah salbutamol, okay, salbutamol. Maknanya lebih kecil lah kan dia punya kepekatan dia. So the keywords untuk patient acute bronchiolitis, because it is not standard to give salbutamol. So bila kita bagi, kita make sure kita check patients punya lung examination, auscultation after we give the nebulization. So if there is reductions, okay, dari segi breath sound improve, okay, better breath sound and less bronchi, then you boleh continue. But for me kalau continue bukan hourly macam asthma lah. Okay, paling-paling pun mungkin 4 hourly. But I don't know kalau nak bagi 3 hourly, maknanya faham tak?
Okay.
Okay, faham. So satu lagi palivizumab ni. This is very, very expensive. I think they pay you. And Galivizumab ni we gave to the patient yang high risk. You tadi tu. High risk tadi kita bagi. So boleh acute bronchiolitis. So differential diagnosis sama macam yang kita cakap hari tu. So untuk dapat distinction, okay, what are the complication related? So kita ada bronchiolitis obliterans. Okay, yang ni you bacalah nanti bila you free Bronchiolitis obliterans. So maknanya as you mentioned itu kita panggil RSV kan. But some patient it is not due to RSV. So it can be due other things. Kadang ada due to other organism. So bronchiolitis obliterans dia complicated by bronchiolitis obliterans. So yang ni pun at least kalau tahu yang ni is a very good lah as a student lah. Apa lagi nak ni? So differential diagnosis dia macam I sebut hari tu lah, viral induced wheeze, multiple maybe asthma for 3 years of age patient or bronchopneumonia with bronchospasm, aspiration pneumonia, foreign body inhalation because dia ada component of wheezing. Yang satu lagi will be your anatomy problem tu vascular ring. Pandai lah tak? So apa yang tertunggu acute bronchiolitis ni? Ini yang tu je lah kok yang in my mind now. So hopefully clear to you and bila datang sini boleh lagi tengok patient lah kan. I don't know, you boleh buat intensive pun. So bila datang sini if really want my help, but you have to come to me because if you did not come to me, I payah nak cari. And I don't know whether you want my assistance or not. So bila you datang sini dari segi bedside, you not ask me to show you the finding to perform the examination, then you have to find me nantilah bila you datang sini.
Okay, Prof.
Sebab kita rasanya so far ni third year masih duduk dekat USM. Okay, tak pergi KB lah. Okay, kalau you balik sini dengan kita kat sini, so you make a full use lah. As a supervisor, you can always approach me. But if you did not come to me, for me mungkin I presume that you did not really need my assistance. Okay, boleh kita stop dulu ke? Sorry kalau siapa ada familiar family punya business ke apa ke. So this is our last week
Jadi maksudnya sebab biasanya kan kita pergi dekat HRPZM, lepas tu kini kita orang memang tak akan masuk ward kan nanti untuk pediatric posting.
For the yang I think the first batch yang masuk sini because masih lagi tak sure ni kan. So yang mana first group ni I suppose dia so far lah our discussion is that you akan stay kat sini. Cumanya siapa yang masuk ward yang tu kita kata kita take turns dengan final year ke macam mana. Because untuk pergi sana dia ada satu risiko lah. Tapi kalau misal kata dekan kata okay, dekan kata no you have to go there, so kita follow sajalah. But so far kalau untuk kita yang among lecturer ni we prefer you to be here lah. Pas masalahnya bila you pergi KB, you dapat infection, you transmit kat kita orang juga. Itu masalahnya. Kalau you seorang dapat tak apa. You buat balik kat our patient dan kita pening kepala. Kan? Kalau datang sini duduk diam-diam sudahlah, kita masih lagi dalam ni. So again dia ada rotation gitu-gitu. So faham? Cuma klinik ada, maknanya you boleh spend time. Tengoklah macam mana because you want to, pandai-pandai lah you nak hidup tu kan maknanya. Tapi kalau the whole group semua pergi tu takut kita tak boleh nak cope juga. Tapi kalau you the last group, mungkin masa tu masa dah berubah. So mungkin you pergi KB. Understand? Sebab kalau macam ni punya rotation mungkin you pergi ni kita dah semua dah cucuk semua dah dapat rotation. So okay dah open macam dulu. Untuk fresh, I rasa masih lagi lah kita buat macam tu dululah.
Okay, faham.
So you kena kerja lagi banyak lah kot dari segi clinical attachment tu untuk compensate lah. Dah miss tu masa kita online teaching. Okay. Rajin-rajin lah belajar tu. Thank you very much for all the preparations and hard working So kalau apa-apa minta maaf lah jumpa lagi nanti. Tersilap bahasa semua tu. Okay. Dan selamat
Prof.
lah selamat berpuasa.
Okay, selamat berpuasa juga.
Okay, Assalamualaikum and
Salam.
bye. I tak my desktop. Okay.